Welcome to Decoding Healthcare Research. I'm your host, Efrain Riveros, Dr. E.F. Rain. Today, we are going to tackle a very important topic in the context of precision medicine. We are going to discuss a paper related to circulating tumor DNA that was published in Nature Cancer in 2020. We have the two authors with us here, Dr. David Chescon. He's a medical oncologist and clinician scientist at the Princess Margaret Cancer Centre, University of Toronto in Canada. And Dr. Lilian Siu, she's a senior scientist of the same institution. It's an honor for me to have you both here. Welcome.
Thank you.
Thank you.
Thank you so much. So the reason we are exploring the topic of circulating tumor DNA is because we are particularly interested in precision medicine, and one of the concepts that is emerging is the use of DNA sequencing in the context of cancer. So my first question to you, I would like to know before we go into the paper. What sparked your interest in this area of circulating tumor DNA? I understand that you work in breast cancer and head and neck cancer, right?
That's right.
James,
so what? Yeah, go ahead.
Sure. So thanks for that, and great question. And this gives us an opportunity, I think, to reflect back a few years to the time where we initially wrote this paper that circulating tumor DNA, I think at the time, was an emerging technology and has rapidly evolved since that time in terms of the potential use cases for it. I think what sparked my interest, and I'll let Dr. Siu comment, but this really arises from the fact that biomarker-directed therapies for cancer is one of, I think, the chief goals of what we try and do: deliver the right therapy to the right patient at the right time, and try and understand whether that treatment is working, change tracks if necessary. And traditional biomarkers that rely on information from the tumor are limited temporally in our ability to assess that information, because getting biopsies frequently or regularly at treatment decision time points is challenging. And they're limited by heterogeneity of tumors, where we understand that different locations of a tumor in an individual, particularly with metastatic disease, may have different features. And so the idea that we can capture this genetic information about the tumor circulating in the blood, which we can collect frequently, repeatedly, and potentially capture that full heterogeneity of the disease in one sample, I think opens up numerous possibilities for precision medicine. And also that serial sampling allows us to understand changes that occur that might provide additional information on how we can tailor therapy once we've initiated it, something that we don't otherwise have ready ability to do.
Yes, and for those like me who are not expert in the field, how would you define a liquid biopsy, and what is exactly circulating tumor DNA?
Great question. So liquid biopsy, I think, historically has referred to a number of potential analytes that could be assessed in the blood. So liquid meaning a blood sample, although not exclusively a blood sample. People have also looked at urine or other body fluids where you can assess tumor-related analytes. And the chief analytes that people think about are circulating tumor DNA in a liquid biopsy or circulating tumor cells. The technologies for analysis of circulating tumor cells have not evolved as quickly, I think, or as dramatically as circulating tumor DNA has. And I think most of our efforts currently are focused on that circulating tumor DNA. So what this liquid biopsy then seeks to do is to capture that genetic material which is shed from a tumor into the bloodstream or into those other bodily fluids, and apply some of the techniques or approaches for genetic analyses to that subset of genetic material that's in the blood that derives from the tumor, as compared to most of the genetic material that's in the bloodstream circulating, which derives from normal cells, and to try and capture the features of that tumor-derived material to understand some characteristic of the disease that might be useful as a therapeutic biomarker.
I see. And probably traditionally, the genotyping of DNA of the tumor depended almost exclusively in the past on the biopsies that you could take, and with the limitations and obviously the invasiveness of the procedure. So how do the genotyping of the circulating DNA compare to the genotyping of the actual tumor?
I think there's been a lot of comparisons. Obviously, you need to have samples that are taken at the same time for comparison. Otherwise, it's difficult to compare a very old tumor biopsy sample to a current blood sample and make a fair comparison. But in studies that have looked at it, concordance that are simultaneously procured, the concordance rate, I think, varies to tumors. Dave can correct me if wrong. I think mostly in the 70 to 80% range in most cases. I think there's been a fairly big study, for example, from Memorial in the impact study that they have looked at it. It's about 60%. And I think with the current technology, we can probably get as high as probably around 80%. I don't think we'll ever reach 100% because obviously it may not be as sensitive at the same time. So what do you think?
One of the important features of ctDNA to understand about genotyping, where, again, genotyping was really one of the first applications of circulating tumor DNA analyses, because we already had a use case for identifying those genotypes that could match certain therapies for certain individuals to treatment. And so applying that in the liquid setting is perhaps the simplest embodiment of liquid biopsy, right? Simply capturing a snapshot of that, of those mutations. And the limitation in circulating tumor DNA is that not every tumor sheds DNA into the circulation, or at least not in large amounts, for which a standard assay has adequate sensitivity to detect that mutation, right? You can only detect the mutations if the circulating tumor DNA is present at a sufficient concentration in the blood, in the sea of normal DNA, to be able to identify that mutation. And of course, the assays that are used to identify that need to be, adequately fit for purpose, understood in terms of the limitations of their sensitivity, understood in terms of the types of mutations that they're looking at. So when those comparisons that Lilian described are done, they need to be interpreted into those contexts as well. So in the setting of high circulating tumor DNA, which is present in many but not all types of solid tumors, with a contemporary assay that has high sensitivity, for a given set of genes, the concordance would be expected to be quite good.
So what would be the factors that affect the ability to detect the new mutations in that circulating DNA? So in terms of anatomy and biology, what are the factors that determine that you eventually are not able to do it?
And to start, like tumor type, like histology, as Dr. Chescon said, matters. Some tumor types just do not shed as much. And even if you look at lung cancer, there's a difference, for example, between different subtypes of cancers in terms of their shedding and not to shed. And we know certain tumors also don't shed as well than others. Obviously, the stage of the cancer matters. A very tiny early cancer is unlikely going to shed compared to, high disease burden where there's tons of tumors in different parts of the body. Likely you will have a very high variant allele frequency, high burden in the liquid component as well, in the body as well. And I guess sanctuary sites too, right? In brain tumors, it's probably much harder than in, liver metastases, for example.
I think some of the, in addition to tumor type, some of the key biological features that are associated with a higher amount of circulating tumor DNA, and again, the more circulating tumor DNA, the easier it would be to detect the mutations within it. Overall tumor burden is a strong correlate of circulating tumor DNA amount across many solid tumors. The location of the disease may matter, so some sites that have more access to the peripheral circulation may have a greater shed. And the proliferative status of tumors also appears to be associated with circulating tumor DNA quantity in at least some tumor subsets. So in breast cancer, that's seen, for example, that more proliferative tumors have a greater shed of circulating tumor DNA into the circulation. And because circulating tumor DNA has a short half-life in the circulation, it's sort of that amount of continuing shed is what determines the level that is detectable in the blood.
I see. Let's explore the clinical application nowadays. Let's use breast cancer as an example. So at what stages of the continuum of diagnosis, screening, diagnosis, and treatment is this technology applicable?
So, great question. And here, I think we need to focus on not only where is the technology potentially applicable, right? Like that there could be future use cases, but where is it currently applicable? Like where is there demonstrated clinical utility? Because those things are not the same today. There are many places where one could envision applying these tests, and many tests are ordered where they may not have clinical utility, or where the test that is ordered may not be fit for purpose. And I think we see this regularly, that someone will have a test done that's not the right test ordered in the right setting, and it provides some information, and that information may be misleading, erroneous, confusing, et cetera. So thinking about what test is ordered, in what setting, and with what goal is critically important. We haven't talked about some of the various applications of circulating tumor DNA beyond genotyping, but there are many different assays out there that use many different approaches. And you could liken it to something like a camera, right? Like if the circulating tumor DNA is what we're trying to capture because we want some information about that person's disease, do you need a camera with a telephoto lens so that you can see some small thing many miles away? But you have to set it up, and you need a tripod and everything else, so you get a one-time detailed snapshot. Or do you want some panoramic lens where you get the most information as possible, but perhaps it's less detailed? Or do you want your camera phone where you can take it out of your pocket and take a picture every 5 minutes, which perhaps are not as well composed, but provide this kind of frequent information? And there are different types of applications for ctDNA that would follow those strategies. So in breast cancer,
yeah, go ahead.
In breast cancer, the main established clinical utility for circulating tumor DNA is in genotyping. And I think that applies, across the board for solid tumors, that genotyping, where we have matched therapies for metastatic disease, is the most well-established clinical use case. And so in breast cancer, we have a small number of therapies that are matched to genotype. So this includes PI3 kinase inhibitors for breast cancers that have mutations in PIK3CA, which is the most common gene mutated in breast cancer in the metastatic setting. And so there we know that you can identify these mutations in patients with metastatic disease, which is where those drugs are used, with pretty high sensitivity. And if you detect that mutation with a standard genotyping assay, so these are typically panel-based assays that are assessing dozens or sometimes hundreds of genes. And if you can see that mutation is present, and using that kind of matched therapy in the appropriate setting would be a use case for that liquid biopsy. If the mutation was not present, then you need to think about, is it not present because it's not there, or is it not present because this is a low ctDNA situation for this patient? They have low shed. And in those cases where it's an established therapy, you might need to go and use a tissue biopsy to exclude that mutation is present. So that example is one which historically has been done on tissue. Those mutations tend to be truncal mutations in metastatic disease. So that original biopsy will contain the PIK3CA mutation. It doesn't change over time, right? So liquid biopsy gives you an easy way to access it, but it's not the only way you could get that information. Another more recent example is with mutations in the estrogen receptor, which arise in metastatic ER positive, the most common subtype of breast cancer, those that are estrogen dependent. And there are mutations in that estrogen receptor that arise when we use our most standard common hormone-based therapy in metastatic disease. And those mutations confer resistance to that standard therapy, but they have also been shown to be biomarkers for the use of a different type of second-line endocrine therapy. And that second-line endocrine therapy has been shown that it is most useful in people whose tumors acquire these ESR1 mutations or the ER receptor mutations. And that's a situation where now you need a biopsy after that patient has had the first-line hormone-based treatment and has progressive disease. And this is a situation where a liquid biopsy is actually very practical to obtain because the person has had their standard first-line treatment. They now have progressive disease. You want to get information about the entire tumor environment, right? Multiple sites. Ideally, do that quickly so that you can make a treatment decision to initiate a second-line treatment. And so this is another established use case where in the US, at least, there's an FDA-approved therapy for ESR1 mutant breast cancer where liquid biopsies, again, as defined by a standard genotyping panel, can be used to identify patients who are eligible for such therapies.
Absolutely. So and one question that came to my mind when I went over the paper is when it comes to diagnosis, how sensitive? I understand that every tumor is different, but how sensitive is the circulating tumor DNA, and how, what threshold of sensitivity would be acceptable for it to be used as a diagnostic tool?
I think it depends on the scenario. One of the scenarios that I wanted to highlight is very often now people are interested in looking at molecular residual disease, where patients have had surgery or some sort of definitive therapy, and they want to know if there's still cancers left in their body. And people who, think liquid biopsy is one size fits all will say, I'm going to get a commercial panel, 500 gene panel, do that test and see if I can detect molecular residual disease. But we all know those panels are not sensitive enough. So if those panels come back negative, it doesn't necessarily mean it's able to detect molecular residual disease. Because in that case, you might have only, very, very, very tiny quantities of mutant molecules in the circulation. And if you don't have the level of sensitivity to look for that little amount of DNA, you will miss it. And you can give a false sense of being negative. And I think that becomes very dangerous in the practice. If you say, anybody just prescribe a commercial panel, there's no mutations present, and they've been falsely assured that there's no molecular residual disease using a not-for-purpose panel, then I think that's very, very risky. In most advanced cases, the burden, depending on the tumor type, obviously, would have measurable enough sufficient amount of ctDNA so that sensitivity is less of a problem in the advanced situation. My bigger concern is in the very early disease setting where you're looking for minimal amounts of cancer. Using an insensitive test would give a lot of false negative results.
So in that continuum, it could be used to detect residual disease or recurrence after treatment, I assume, but also as a screening tool. So if you can characterize those two situations, which one has more applications, the screening part or the follow-up part?
So I can comment on that. So again, quite different use cases, right? If we're thinking about cancer screening and for solid tumors, right, there are many established cancer screening approaches, mammography for breast cancer, colorectal cancer screening, which can be done in different ways, where the goal is initial detection of those cancers, right? And those are mostly focused on common solid tumors for which there's interventions available. Cervix cancer is obviously another example. So there is a large effort underway to develop what are called multi-cancer early detection tests, which are looking for signal in the blood of one or more cancers that may be arising. And ultimately, it needs to be understood how such tests could complement or potentially replace or augment existing screening programs. The challenge with those kind of tests is that most patients who are healthy, who would have such screening, don't have cancer. And therefore, you need to have sensitivity to detect a cancer at a very early stage. But you also have to have very high specificity so that you're not having false positives tests, which could, swamp out the true positive test just based on the sheer number of healthy people that are screened. So those tests also have to be developed in a way that they're looking for common features of those cancer where we don't already know about that individual person's cancer, right? We can't say we're looking, for a breast cancer with X, such and such a mutation that we know that person already has, because a priori we don't have that information. So there are many large efforts that are underway, national screening programs, clinical trials with hundreds of thousands of people in it, because that's the level of investigation which is necessary to prove and establish the potential utility of those tests, and ultimately to compare them to standard screening tests. The other situation of this recurrence disease detection, which is what Dr. Siu was mostly alluding to, this idea of molecular residual disease, is one, I think, which is closer to our areas of clinical and research interest, because it directly impacts therapy, right? As medical oncologists, a lot of what we do is to try and prevent metastatic disease by delivering curative intent systemic therapies after someone has had definitive surgery or as a component of that definitive therapy in the head and neck context, right? So someone has their cancer. We know that with surgery alone, they're still going to face a recurrence rate of 20 or 30%. And so we use chemotherapy or targeted therapy or hormone-based treatment just based on the probabilistic risk that person has based on tumor size, lymph node status, other features of the tumor, right? But we don't know, is this person going to recur or not? We just know they have some risk of recurrence. And we weigh the risks and benefits and use adjuvant therapies that have been, or neoadjuvant therapies, preoperative therapies that have been shown to improve outcomes. I think the possibility of circulating tumor DNA in this context is it gives us something to look for and measure in someone who appears to be disease-free, right? They've had their surgery, their CT scans are clear, but we don't know if this person who has a 30% risk, are they one of those 30% who will recur, or are they one of the 70% who are already cured by the treatment that they've had? So here's a situation where perhaps a tool like this could allow us to move from this kind of probabilistic approach to adjuvant therapy to a more deterministic delivery of therapy to those people who have evidence of residual disease that historically we have not been able to identify. And so as Dr. Siu was alluding to, this is a situation where we need to be able to detect that amount of circulating tumor DNA that may be present with incredible sensitivity, right? And so to put that into context, when we think about these genotyping assays for patients with metastatic disease, there you're looking for, most of the assays have levels of detection of a 0.3 variant allele frequency. So, 0.3 out of every 100 alleles of that DNA are derived from, or mutated and derived from the tumor. Whereas in this molecular residual disease context, where again, no metastatic disease is evident on a CT scan, we're trying to pick up those very small signals from whatever microscopic disease is present. The levels, the limits of detection that are being investigated in the current generation of assays are on the order of 1 in 100,000 to 1 in a million variant allele fractions, so several orders of magnitude more sensitive. And to achieve that requires a different approach, because when you get to that number of genomic equivalents in the blood, right, any blood tumor, any blood sample that you take only has so much DNA in it, so much cell-free DNA, so that even if there is circulating tumor DNA in the person's body, it may or may not be, like a given variant allele frequency for a given alteration may not be present in 1 tube of blood or 2 tubes of blood, right? So some of the strategies that are being used to overcome this are, you could collect larger amounts of blood and test large amounts of blood to see, can you find more tumor DNA in a larger sample, but that's challenging to do. And obviously there's a limit to the total amount of blood you can do. The other way to do it is to look for more signals, right? So rather than just looking for one signal, like PIK3CA, one of the mutations that we talked about, and say you either see it or you don't. You say, well, let's look for many signals that we know are present in this person's tumor. And if we find any one of them, or any few of them, out of all those that we know, then we will know that that tumor is present. And so the latest generation of assays that are looking at molecular disease are constructed in such a fashion where they may look at dozens or hundreds, or in some case more, tumor-associated variants. And in some cases, those assays are individualized assays where the person's tumor, which again, these are people who have been previously diagnosed with cancer and had localized therapy. So that tumor can be exhaustively characterized with exome or genome sequencing, find all of the alterations that are present, and then create an individualized assay to go looking for any of those alterations in the blood. So if you think about it like a needle in a haystack problem, instead of saying, I'm looking for just this one needle in a haystack, right? It's the blue needle in the haystack, and I want to find the blue needle. Say, well, I don't care whether it's the blue needle, the pink needle, the yellow needle, or the green needle. I know that there are all these different needles, and if I find any one of them, I know that there's some needle in the haystack. And so these approaches have led to this increased sensitivity, and the use of those assays is now being clinically developed so that we can try and understand the utility of their application. And so that's really a significant piece where, again, both of us are engaged in some active research to try and understand if we can detect this. Like now let's say, yes, we can do it, right? We know we have assays that can detect these early signals, but what can we do about it, right? What are we really detecting? Are these people who have the potential for cure if we have, and do we have therapies that we could use to intervene, or what's sometimes called intercept those recurrences, right? Guide a therapy based on that. But we don't know the answer to that question. I think in the vast majority of clinical contexts, certainly in breast cancer, we don't know the answer. Can we act upon that information and change that person's outcome? In head and neck cancer, I think it's probably the same situation. So what we need then are clinical trials that test these tools, right? And test a strategy associated with one response, with the presence of circulating tumor DNA to ultimately, hopefully demonstrate that we can change the natural history of the disease. Where the natural history, unfortunately, is if the what's this called MRD, molecular residual disease, or some sign of the tumor remains after that person has completed the standard therapy, they will recur if it's identified with the proper test. There are other tests which might give a signal which is not derived from the tumor. And again, this is one of those liabilities of using tests that are not fit for purpose. You can either have false negative tests, so be falsely reassured, oh, we did this standard test, which was not meant for this, it was negative, so therefore you have no risk of recurrence. We don't even know that with the most sensitive tests are not adequately sensitive. Or you can say, hey, we found this P53 mutation in your blood with this test. You must be at risk for you must have some cancer left, and you're going to have a recurrence of your breast cancer. But that P53 mutation might be derived from some clonal hematopoiesis or some small number, of blood cells that carry such a mutation where it's not tumor derived. So the risks of false positives, false negatives, and the untoward conclusions or risks on therapy of that information, I think, is a very real concern in the current environment. And so understanding what a given test can do, understanding, how any information from that test could be used, and I think really developing prospective, well-designed clinical trials to try and tease out all of these unknowns is really where we need to be focused now, rather than commercial ordering of tests just because they're out there to be ordered.
Yeah, and that's actually my next question, because it's clear that when it comes to treatment of cancer, it's a multidisciplinary team that is involved. And as the sensitivity of the test improve, embracing the technology by all the team is critical. So my question is, in the oncology community, Is this type of test being considered all the time, like a first line for follow-up for recurrence, for instance, or we need more education directed to the physicians?
I would be a bit careful because not all these tests are funded, and we don't want people to just randomly order it or have expectations, because I think we need to gather evidence first. And I would say in the order of proven utility would be more in, first of all, metastatic setting, using it to do genotyping, especially when tumor tissues are not readily available. I think there's more evidence for that. The situation for molecular residual disease is less evidence-based. I mean, there's some data for doing that in colorectal cancer. Probably that's the most advanced. There's most evidence for that. But even there, it's not available in all countries and not available in all settings. And in the setting of very early screening in patients without cancer, that we're still at the stage of gathering evidence. Perhaps in the higher risk patients, there is potential more utility than, you know, a 30-year-old healthy person who has no comorbidity. I'm not sure that at this point there is sufficient sort of room for that without doing, you know, large volume, large patient population analyses. So I think to answer your question, the awareness is important, but more importantly, to contribute to adding the data, the evidence is much more important at this point to support the use of them, and not just randomly ordering any test in any situation. That's not the right thing to do.
I think to follow on that, I think, and I agree with you that the multidisciplinary education, understanding, and consideration of how these tests could be used and what their liabilities are is critically important. And again, while these tests are out there, while these tests are being marketed to patients and providers with early stage disease, you need to understand that the sensitivity of these is not such that if one has a negative test, either before surgery or after they've had whatever their drug-based treatment, it means that you can omit any part of their standard therapy, right? Many patients with early stage disease who have had surgery will not have detectable ctDNA, even with the most sensitive tests available today. And the worst thing that could happen today, to harm patients, is to say, I ordered a test, even if it is a highly sensitive test, worse if it's a less sensitive test, and it was negative. Therefore, you don't need radiation as adjuvant radiation for your breast cancer, or you don't need adjuvant endocrine therapy, or you don't need, whatever the adjuvant chemotherapy is for that given disease, in the absence of high quality prospective evidence to support the utility of a given assay, or at least an assay with given test characteristics to support that application. And even in colorectal cancer, where those kind of studies have been done, there's studies published in the New England Journal of Medicine looking at some ctDNA tests and informing adjuvant chemotherapy for stage 2 colon cancer. The test that is used has to be the right kind of test. And there are many other kinds of tests out there, like those genotyping tests, which don't operate in the same way, right? Like a genotyping test that is looking for a 0.3% variant allele frequency will be negative in essentially all patients with early stage cancer after they've had surgery, right? The tests that are used in some of these adjuvant studies are much, much more sensitive, and you can't substitute one for the other, right? So a ctDNA informed strategy, I think this is where education is important. A ctDNA informed strategy, people need to think about this as, the type of ctDNA test, right? Is it a highly sensitive MRD focused test? Is it a genotyping focused test? And to think about the evidence as it is generated in that way, and not substitute one for the other. Just like we wouldn't read about the latest cancer therapy in the New England Journal and see it just described in the title and the abstract as targeted therapy for cancer. It would be described as what type of targeted therapy is it, and how is it used? And I think one of the failings of much of the communication about the evidence of ctDNA currently is that to really understand the techniques that are used in many cases, you got to dig into these, methods or appendices to try and understand what are the characteristics of that test that was used. And the top line result, ctDNA can be used to inform adjuvant therapy in colorectal cancer, is meaningless without an understanding of what type of ctDNA tests might be useful in that setting, and what type of test might be very dangerous if you use it inappropriately in that setting by potentially exposing patients to either omission of proven therapy or unnecessary therapy on the other side.
Yeah, I see deep knowledge and critical thinking are super important here. So assuming that the test is used in the setting of good evidence, what can we say about cost effectiveness when you compare it to other tests?
So here I think we're looking at a pretty limited set of settings where cost effectiveness can only be considered once clinical utility has been demonstrated, right? If there's not clinical utility, we can't think about cost effectiveness, or cost can't be effective unless there's clinical utility. So for a genotyping example, I think here I'm not aware of specific comparisons of cost effectiveness of one approach versus the other, but you could imagine that a blood test that can be drawn at essentially no cost, right, or very small cost for phlebotomy, sent in a tube, have that test performed, could be quite cost effective compared to the need to do a interventional guided biopsy, collect the sample, do the pathology, et cetera, and then to carry out similar genotyping analysis. So I think there are situations there where one could readily calculate the cost effectiveness and the other impacts on the process of care for genotyping. In this molecular residual disease setting, I don't think we can really understand the cost effectiveness because there's not the same breadth of understanding of clinical utility. The potential cost effectiveness in this case, I think, is enormous, though, for two reasons. One is that the thing that's furthest away, I think, currently is can we omit some kind of therapy for patients, right? Like, are people getting unnecessary therapy that we can avoid? And those type of strategies can be extremely cost effective if you're avoiding expensive or toxic therapies. And we've seen examples like that in breast cancer with tumor-based testing, where we can avoid chemotherapy with things like gene expression-based assays, Oncotype DX or MammaPrint. And so we can now avoid giving chemotherapy to people where we had historically given chemotherapy with a tissue-based genetic test, right? And those things are shown to be cost-effective. For the treatment escalation perspective, right? Let's say we have a new therapy which we think can reduce the risk of recurrence in a given cancer, and we could give it either to all people who are at high risk, where where high is defined by whatever parameter it's defined by, to benefit a small percentage of patients. So treat 100 patients to benefit the 5 who might benefit from it, right? Any therapy like that, the cost effectiveness is driven by how many people need to be treated versus how many benefit. If instead you could test all of those people, identify the 5 who really needed the therapy or who could really benefit from the therapy, and treat only them, then you have an opportunity for cost effectiveness based on reducing unnecessary drug costs, where the cost of drugs can be high, avoiding unnecessary toxicity and time costs and impacts on productivity, work, home, all of those things where there's potential for cost effectiveness. For tests that cost on average from the many hundreds to several thousands of dollars, depending on what situation and what application is being used. So there's clearly opportunities for cost effectiveness, but I don't think we understand what and where that might sit today, and we won't until we understand the clinical utility. I think we need to be thinking about it, though. Like if a test is if a test costs $5,000 to perform, and you need to be able to perform it every 3 months in follow-up for a patient to be able to capture that information about molecular residual disease, is that something that has a future, right? Could you ever have a test that has those costs if it's something that has to be done repeatedly? Maybe if it was only necessary to be done once, such a thing could be cost effective. But repeated testing, which is probably quite important for molecular residual disease, or this idea of cancer interception rate, picking things up while the ctDNA is rising because there's some tumor growth, but before those patients actually experience a recurrence where you might be able to intervene. That kind of repeated testing is another way to maximize the capture rate, right? Because you're not looking just once, but you're looking at all of those different time points.
Yeah, and it's definitely work in progress to determine the real ratio between cost and effectiveness. And Dr. Liu, you mentioned something interesting, that we are at the stage of collecting evidence. So my question is, what is coming next in terms of research to close that gap so that we start transitioning in the future to clinical applications and widespread use of this?
Well, there's a lot that is happening. Obviously, you heard a little bit about the molecular residual disease in terms of patients who've had definitive treatment. We're trying to detect these small quantities of ctDNA so that we can intervene, intercept with drugs and hopefully, or other therapies, to cure these patients who are destined to relapse again. And maybe we can therefore treat a very tiny group of patients without having to treat everybody with adjuvant therapy or high toxic therapies. So I think that's definitely an area of focus. There are a lot of ctDNA tests that are not just based on mutations. For example, we're interested in looking at methylation patterns and other circulating biomarkers to detect molecular residual disease or detect cancer signals in those patients. I think, the research is really trying to make sure that we're not just randomly doing these tests with different panels that are not yet proven to be fit for purpose. To use the right panel or right test for the right time, I think that education is important, not just the scientific studies, but also the educational aspects. I think it's really, really important. And to some extent, what you brought up about cost effectiveness, I think that is understudied. Obviously tissue versus blood, and to do the test versus not to do the test. In some cancers, I think perhaps liquid biopsy is not cost effective for genotyping, when there are no, circulating actionable mutations, for example. It's not going to help you because whether you do tumor or blood, it doesn't matter. You have no actionable variants present in the genome. Perhaps the answer will be more in transcriptome or, surfaceome, rather than, what's in the genomic aspects of the cancer. So I think that's an important aspect as well, that I think it is understudied.
I see, and it's actually a very exciting field, and I think we are coming to a close by saying thank you so much for this comprehensive review, and I am sure that our audience is going to enjoy it significantly, especially because you were able to present it in a very comprehensive way and easy to digest. So I want to thank you both for sharing your time and wisdom with me and with our audience today. Thank you so much.
Thanks for having us.
Thank you. And for our audience, the link to the paper is going to be posted on the description of the video. And don't forget to leave us your feedback. See you in the next episode.